Hi, so today we're going to be reviewing a couple cases from our biochemistry course. And the first case that we're going to be looking at is case number 1. For this case, a newborn girl appeared normal at birth. However, within 24 hours, she developed lethargy, hypothermia, and apnea. So, the attending physician suspects a metabolic disorder and decided to order a panel of labs. So the question is, which diagnostic would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation? So we're going to be discussing all of these options. And so option number 1, we have blood glucose. Option number 2, we have urinary acids. Option number 3, we have serum fatty acids, and option number 4 is plasma glutamine. So, after ordering a full blood workup, this female and the data is as follows. So, the initial blood ammonia level was elevated. So, that was at 314 micrograms per deciliter. The normal range is about 17 to 80. And then this rapidly rose to 600. And then the urine orotic acid level was markedly elevated at 473 micromoles per liter for creatinine. Typically, that's nanoliters between 0 and 3. And then the plasma citrulline level was normal at 10 micromoles per liter. So, what we see here in this patient where the orotic acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. So we're going to go ahead and look at that as well. So to begin, we're going to look at each of our options and discuss how they would relate to the presenting symptoms and possible metabolic disorders. So first, blood glucose lab probably wouldn't result in the symptoms being experienced by the patient. This panel would not be suited for addressing disorders of the urea cycle or beta oxidation in this scenario. Next, while a urinary acid panel is helpful in determining the presence of excess ammonia, this panel may not actually be beneficial in determining if any issues are occurring with beta oxidation. As far as the serum fatty acid panel, this would be helpful in assessing if there was an issue with beta oxidation, but not necessarily issues with the urea cycle. Finally, we have plasma glutamine, and in order to distinguish between a urea cycle disorder and a disorder in beta oxidation, this would probably be our best choice based on the symptoms and also from the results of the blood workup. Since glutamine does act as a carrier for ammonia, a deficiency in the metabolism of ammonia would also impact the glutamine levels. Glutamine synthetase facilitates this reaction and assists in the detoxification of ammonia. So since both glutamine and ammonia levels would be elevated, looking at the plasma glutamine levels is our best option, as glutamine levels would actually appear normal in the case of beta oxidation disorders. So, it's likely that the infant is experiencing ornithine transcarbamylase deficiency or OTC deficiency. Given the symptoms of lethargy, hypothermia, and apnea, also coupled with the onset of the symptoms occurring around 24 hours after birth. Other symptoms can also include poor feeding, irritability, vomiting, ataxia, seizures, hepatomegaly, and coma. The elevated levels of both ammonia and orotic acid are indicators of deficiency within the urea cycle, as you can see over here. So since the orotic acid levels are elevated, yet citrulline levels are normal, this would actually be pointing to the enzyme, the ornithine carbamyl transferase, which is right here. So that would result in the levels that we are seeing. And then to address the question of the enzyme least likely to be impaired, the enzyme least likely to be impaired could possibly be this carbamyl phosphate synthase, which is shown right here. So this enzyme assists in the initial step of the urea cycle process, which probably wouldn't result in the levels that we did observe. So next, we're going to look at case 3. And case 3 is a 47-year-old man presents with severe pain in his right great big toe. So he is unable to bear weight on his right foot, and there is no apparent trauma. He reports that the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and a urine analysis is performed. So the results from this individual are as follows. So here we have the results for this individual. As you can see, normal levels would be less than 7. This patient actually has 10.5 milligrams per 100 milliliters of plasma urate. And then as far as urinary uric acid, the normal range is 413 plus or minus 78. And then this patient has 215. So the question is, what is the best explanation for the presentation of gout in this individual? And please explain why the other choices are not consistent with the data, or what additional information you may need to decide the root cause. So we're looking at these 3. Number 1, overproduction of purines. 2, decreased salvage of purines. 3, decreased urinary excretion of uric acid. So another little piece of information is, after further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that the fake sugar diet soda was bad for him. He tells you he drinks between 4 and 5 liters of soda a day. And just a little note, the primary sugar in most sodas is fructose or high fructose corn syrup. So we're wondering, what is the potential impact of this dietary modification on the presentation of gout? So we're going to switch over to this image, which is showing the process of how purines are metabolized and eventually exit the body via uric acid, or in the form of uric acid. So to start off, gout typically manifests due to an accumulation of uric acid in the body. This can result from the formation of uric acid crystals. So these deposits tend to appear in joints and creating inflammation and pain. For this patient, while plasma urate is elevated, urinary uric acid is relatively normal. So looking at our first option, it doesn't seem likely based on the patient's results. Overproduction of purines will result in higher levels of uric acid. Additionally, there is a feedback mechanism that exists which would prevent the overproduction of purines, unless there was a deficiency in that process as well, which we don't know. Our next option, decreased salvage of purines. This typically would occur with Lesch-Nyhan syndrome. This syndrome occurs with the deficiency in the enzyme hypoxanthine guanine phosphorybyl transferase, HGPRT. In this scenario, we would observe an increase in uric acid as well as an overproduction of purines. So that's not exactly what we're seeing. The patient may be taking a xanthine oxidase inhibitor. That could reduce uric acid levels. So it would be helpful to know if the patient is currently taking any medications for the treatment of gout. I think that would be helpful to kind of pinpoint a little bit more information. In addition, after this patient has shared their recent transition from diet soda to regular soda, this potentially has an impact on the presentation of gout given the relationship between increased fructose consumption and uric acid levels. So the excessive consumption of fructose may have prompted this recent flare-up for the patient. And that is all. So thank you so much and have a great day.